Today we're diving into a topic you might not expect in PT, renal and urologic disorders, problems with your kidneys, problems with your bladder. You might be wondering, I'm a PT, I work with muscles and joints, why learn about kidneys? You're already treating patients with these conditions. They're surprisingly common in older adults, people with multiple chronic diseases. The kidneys aren't just filters, they're master regulators. They control blood pressure, they manage fluid and electrolyte balance. They produce hormones for red blood cell production. They help maintain bone health. When these functions go haywire, patients struggle to participate in therapy. Ignoring that is like building a house on a shaky foundation. Because renal, urologic symptoms can mimic musculoskeletal problems. A patient might complain of low back pain, which could be referred pain from a kidney infection. They might report extreme fatigue and weakness. You might call it deconditioning. But it could be anemia from chronic kidney disease. The big one is chronic kidney disease. This is a progressive loss of kidney function over time. Think of it as the kidneys slowly getting worse at filtering waste from the blood. It's often caused by other common conditions like diabetes and high blood pressure. Patients can range from mild dysfunction to needing dialysis. This is a systemic disease. It affects energy levels and bone strength, highly relevant to your work. Next up are urinary tract infections. These are incredibly common, especially in older adults and women. A UTI is an infection in any part of the urinary system, most often the bladder. Symptoms can include pain, urinary frequency, and urgency. In older adults, the primary sign can be confusion, delirium, new onset falls, or weakness. This can be mistaken for a neurological event or simple aging. Urinary incontinence is the involuntary loss of urine, a symptom, not a disease. Stress incontinence is leaking with a cough or sneeze. Urge incontinence is a sudden intense urge followed by leakage. It's prevalent in postpartum women, older adults, and those with neurological conditions. It affects quality of life, activity, and fall risk. Pelvic floor physical therapy is a frontline treatment. Now that we know the players, let's talk about how they affect the game. One of the most pervasive symptoms, especially in CKD, is profound fatigue and weakness. Often due to anemia, failing kidneys don't produce enough erythropoietin, which signals red blood cell production. Fewer red blood cells mean less oxygen to muscles, poor endurance and intolerance. Your standard 3 sets of 10 might be unattainable. Fluid and electrolyte imbalances, Na, K, Se, phosphate, disrupt muscle, nerve and bone. Potassium highs or lows cause arrhythmias and weakness. Calcium phosphate imbalance leads to renal osteodystrophy, fragile bones and fracture risk. Be extra cautious with manual therapy, modify weight bearing, and prioritize fall prevention. Kidney-related pain limits walking, bending, and sitting. Posture and gait may compensate. Urgency and frequency disrupt sleep, causing daytime fatigue and increasing fall risk. Schedule PT on non-dialysis days or well before. AV fistula or graft is a lifeline. Protect it. Understanding these limits is non-negotiable for safety and trust. When working with renal or urologic issues, your primary directive is to do no harm. Be acutely aware of risks and modify interventions. The biggest risk is cardiovascular stress. BP can spike or drop unpredictably. Strenuous exercise can raise BP. Recovery can cause hypotension and falls. Monitor vitals before, during, and after every session. Dialysis patients have strict fluid limits. Exercise can increase thirst. Watch for overload. Overload causes shortness of breath, even heart failure. Heat dehydrates, and risks, stones, UTIs. Encourage prescribed intake. Look for dizziness and dark urine. Watch for swollen ankles and shortness of breath. Renal osteodystrophy makes bones brittle. Avoid high impact and forceful techniques. Think low impact. Aquatic is excellent. Screen for open wounds and incontinence. Untreated UTI or severe acute flank pain. Stop and refer immediately. Watch fistula for redness, swelling, pain. Be the vigilant monitor and prioritize medical issues that day. A thorough assessment starts with a detailed subjective history. Be a detective, ask questions, check vitals, inspect skin, observe movement, urination changes, painful, unexplained fatigue or ankle swelling. For CKD, ask dialysis days and where the fistula or graft is. This guides your plan of care. Monitor blood pressure and heart rate at rest, during exertion, and after. Systolic BP that fails to rise or drops with exercise is a huge red flag. Press for pitting edema. Lingering indentation signals excess fluid. Listen for crackles. Ask about shortness of breath. Pale or sallow skin suggests anemia. Dry, itchy skin can signal uremic toxins. Exhausted from waiting room, guarding back, abdomen. New confusion. Think UTI, systemic issue. Stop and communicate for sudden BP changes. Chest pain, SOB, DVT signs, acute flank pain, altered mental status, or infected dialysis access. Recognizing these signs makes you a responsible provider. Communication is everything. Explain BP monitoring and exercise choices. Confirm exercise parameters to keep everyone on the same page. When prescribing exercise, think start low, go slow. Use the Borg RPE scale. Many patients on beta blockers have blunted HR response. Aim for an RPE of 11 to 13 to start. Prefer intervals, 3 to 5 minutes of light activity, then 1 to 2 minutes of rest. Gain benefits without excessive fatigue or hemodynamic instability. For dialysis, best time is the day after. Avoid PT immediately after dialysis. Protect the access limb. No BP cuffs, no restrictive bands, no heavy lifting. Ask and document the access arm at every initial evaluation. Include balance and functional tasks every session. We can't talk about urologic disorders without the pelvic floor. This group at the base of the pelvis is a powerhouse of function. It supports pelvic organs, maintains continence, and contributes to sexual function and core stability. PTs uniquely assess and treat these muscles with conservative care. Many believe the only solution is more Kegels, but it's not that simple. Some have a hypertonic pelvic floor, constant contraction causing urge incontinence, pelvic pain, or hesitancy. Focus on relaxation, down regulation, coordination. Teach diaphragmatic breathing and specific stretches. Others, especially postpartum or older adults, have weakness causing stress incontinence with cough, sneeze, laugh, lift. Go beyond squeezing, isolate, contract, relax, then integrate into function. Teach the muscles to turn on at the right time with the right force. You don't need to be a specialist, know the basics. Screen for leaking, urgency, or pain. Teach diaphragmatic breathing, and know when to refer to pelvic health colleagues. Meet Robert, 68, referred for weakness and poor balance after pneumonia. History includes diabetes, high blood pressure, and stage 3 CKD. He lives alone and wants to walk to the corner store. He's exhausted, wakes multiple times nightly to urinate and feels groggy. BP is 150 out 92, with ankle edema and pale, dry skin. Fatigue is multifactorial. Deconditioning, CKD anemia, poor sleep from nocturia. Use RPE 11 to 12, short walking intervals with rests, full vitals monitoring, and balance functional work. Send findings to his physician to optimize medical management. Work safely on functional goals as his care is coordinated. Renal urologic disorders have systemic effects that directly impact PT. Assess, monitor, and modify. Start low, go slow, protect access limbs, prioritize safety, keep learning.